Hi, thank you so much for joining us today. Before we get started, I want to thank C4 for hosting this webinar and inviting me to speak to you about using measurement-based care and outcomes research to improve treatment effectiveness and your bottom line. A couple of housekeeping things. You can access a Q&A if you have any questions that arise while you're listening to the presentation. Please type them into the questions and answers box, and we will have a few minutes at the end of the webinar to answer those questions. So also there will be a poll at the end. I'd appreciate if you'd spend a moment and tell C4 what you thought about this webinar before you head off to the rest of your day. So anyway, thank you again for joining us today. My name is Joanna Conti, and I am founder and CEO of both Vista Research Group and Conquer Addiction. And I want to start by telling you a little bit about how I became interested in the addiction treatment world. I had a daughter who became a very serious alcoholic, and she was in and out of treatment for a number of years. And we kept being put in a position where she was in the emergency room with, basically a lethal level of alcohol in her system. And we had to find treatment for her immediately. And each time we were kind of forced to, rely on a chance conversation somebody had made, and then calling a treatment center that had been recommended and talking to somebody who sounded really nice on the phone. And when I said, what's your success rate? They would say, trust me, we're better than the rest. We have been very blessed. My daughter was able to every time find excellent treatment. And as a result, she's getting ready to celebrate 6 years of sobriety. So we have a tremendous amount to be thankful about. But when the worst was behind us, I started to think there has to be a better way for the families coming behind us to find the treatment centers with the best possible success rates. So as a side project, I decided to start an organization called Conquer Addiction, where people could search for treatment centers that met their needs, and the ones that had the best post-treatment outcomes would show up at the top of their search. So I built this wonderful little website as a labor of love, and was able to find a grand total of 5 treatment centers in the whole country who were tracking their outcomes and would report the results to us. So I thought, well, I can't start promoting a website that has only 5 treatment centers recommending, Karen and the 4 foundation centers. So I went to one of the addiction treatment conferences that year, which was in 2015. And I started talking to treatment center owners. And I said, I don't understand. Why aren't you tracking your post-treatment outcomes? And I heard from enough people who said, we want to, it's in next year's strategic plan. We don't have a clue how to do it. That I said, we can figure out a cost-effective way to provide this type of research to the addiction treatment industry. I have a very unusual background. I'm a chemical engineer. I have a master's in marketing. Along the way, I taught myself how to program and started a software company. I've also, of all things, run for Congress. And I thought, this isn't rocket science. We can figure out how to do that. So I started Vista Research Group in the fall of 2015 to develop outcomes research for addiction treatment industry. And shortly after that, I discovered all of the research that showed that if you monitor patients while they're in treatment and report those results to the clinicians treating them, that patients get better faster. And I thought, well, okay, obviously we should add that to what we're offering to our treatment clients. So we've kept adding more and more product lines as the needs of our clients have grown. I do have to be very open. I am the owner still of Vista Research Group. We have several different products, and we are in the process of relaunching Conquer Addiction as a nonprofit, because we finally have enough treatment centers that are tracking their outcomes. So with that as a background, let me say that it is totally clear that data is going to dramatically transform addiction treatment. As Peter Drucker said, what gets measured gets managed. And in the last couple of months, I've become aware that there is that our addiction treatment clients are going through a very difficult time. Not only do they have to comply with all sorts of regulatory changes and changes in the payment structure and changes in the way that marketing is done, but they're also being required to use new quantitative tools for the first time. So I wanted to let you know that we've just released a report called The State of Addiction Treatment that is hot off the press. I was able to have wonderful sections written by Harry Nelson of Nelson Hardiman about the regulatory challenges facing addiction treatment, from Dexter Braff about the merger and acquisition market, and also from Ben Dittman of Avea Solutions about what's happening in the payer market. If you're interested, please go ahead and download the ebook or the report at stateofaddiction.com. So now let's get going. We're going to cover two different types of things today. The first is we're going to talk about monitoring patients during treatment. We're going to cover why it's beneficial, how you can do it, and how you can use your results to improve treatment effectiveness. Then we're going to talk about following up with patients post-treatment and why you absolutely want to do it and how to do it well, and then how you can use your results to improve your bottom line. And then at the very end, we're going to cover 3 years of Vista's outcome research results, which are hot off the press as a special bonus. So let's dig in. We're going to talk first about monitoring patients during treatment. So there's no question that reducing the severity of co-occurring disorders helps patients in addiction treatment get better and stay in active recovery. Dr. INGRID CARLIER did a meta-analysis a couple of years ago that compared 45 different mental health related clinical trials. And what she found was the process of getting information directly from the patients and reporting it back to the clinicians helped patients get better faster in 2/3 of those cases. In fact, when they focused on specific mental disorders, the increase went to 76% made a difference. And all 3 of the trials that focused on addiction treatment showed that progress monitoring helped patients get better faster. And the reason why it works, different research has shown, is that clinicians have a tendency to overestimate how well their patients are doing. If a patient comes in to treatment and maybe makes a modest improvement and then plateaus, the clinician might assume that that patient is continuing to improve. But confronted with the evidence showing that the patient has been, moderately severely depressed for the last 3 weeks in a row, then, the clinician will be, it will be very apparent that they need to change the clinical treatment plan. So the Joint Commission was looking at this same data, and they decided that the research was so clear that this improved treatment effectiveness that they required, starting the beginning of 2018, that all accredited behavioral health care organizations start using some sort of progress monitoring by January 1st of 2018. And there's a lot of different terms for the same things: progress monitoring, outcome measures, performance, patient-oriented feedback, FIT, feedback-informed treatment. They all kind of mean the same thing. It's kind of confusing. What the Joint Commission requires is 3 things. They require that you use a standardized tool or instrument to monitor the patient's progress, and they want it to be from the patient itself. Secondly, you need to use the results to inform the individual's treatment plan. You need to be able to show the Joint Commission you're doing that. And third, you need to periodically aggregate the data so that you can evaluate, is your performance improving over time? How do you compare to that of similar treatment programs, et cetera? So I'm going to talk about how we collect useful data, but I'm going to frame it in a larger perspective, assuming that you might want to create your own progress monitoring system. We will show what we have found is most effective, and I'll use examples from our Insight Addiction line to show you how we're doing it. But I'm hoping that, if you decided that you were going to build your own system, that this would give you the information that you would need to accomplish that. So as we think about how do we design an effective progress monitoring system, there's really 4 different groups of people we need to make sure that we're meeting their needs of. The first is we need to make sure that the data that we collect from patients is useful and insightful. The second thing is we need to make sure it's data that your clinicians will value and will understand. And third, we want to make sure that we minimize staff effort in collecting this information as much as possible, because at most addiction treatment facilities, staff has an awful lot of different requirements on their plate. And then there's a 4th group to think about, and that is your management team. You want to be able to have data that when it's analyzed and compared to benchmarks, your management can use that to assess how your treatment facility is doing. So let's talk about each of those sections at a time. In terms of insightful patient data, measures that you use need to be clearly academically validated. They need to be designed for self-report. They need to be sensitive to change. If you're using a scale that asks, in the last year, did you experience X, Y, Z? It's not going to be any different, the results you get 2 weeks from now, than the results you get today. And so that you don't have a lot of patient pushback, it needs to be reasonably quick to take. And then I have a personal preference. I believe that we ought to allow our patients to tell us what issues that they are struggling with. How we do that in Insight is we ask some very simple yes/no questions at the beginning that have been shown academically that if a patient answers any of those questions positively, they are likely to be depressed or to have PTSD symptoms. And so they are telling us what issues that we need to dig into further and take them to a full academically validated symptom severity scale. So how do you pick insightful patient data? Obviously, it needs to be the measures that are most relevant to the patient's recovery, and this will vary by the type of treatment you're providing. What we found in addiction treatment is we want to screen all patients for the common co-occurring disorders that go along with addiction: depression, anxiety, trauma, eating disorders. We also want to screen for suicidal thoughts and self-harming behaviors, for cravings, for are they using drugs and alcohol during treatment, how satisfied are they with treatment, and for those patients that are in IOP treatment or outpatient treatment, how frequently are they attending treatment. Now, for behavioral health care, what we've done is replace the focus on drug and alcohol use with screening for some additional common mental disorders, mania and psychosis, for example. We also have a medication management module, and there's an optional module for functioning for the severely mentally ill. Now, in detox, we have created a separate survey that just focuses on what's most important to that patient during that acute withdrawal phase, which is basically the strength of their emotional and physical withdrawal symptoms and their suicidal thoughts and cravings, etc. And this shortens, the research involvement when they're not necessarily at their best. But in psychotherapy, the most important measure might simply be what is the strength of the therapeutic alliance. So as you think about what is most important to measure, you need to decide, what for this particular population of patients do you think is most important for you to monitor and track over time. Now, secondly, you want to make the data very easy to use and understand. I think there's night and day difference between, asking patients to take a survey on a paper survey, and then, days or weeks later, somebody analyzes those and goes back and reports the results. In order for your data to be really usable, it really needs to be available to the clinicians in real time. And it needs to be in very easy to understand graphs. This is what we do with Insight. We show the black bar on the left is how the patient reported feeling in the 30 days before they began treatment. So you can say that this patient came in reporting to be severely depressed. And then we track over the time they're in treatment how the patients are improving. And all of this information is available on a patient dashboard in real time for patients after they submit surveys. It's also important to have an ability to alert clinicians to dangerous thoughts or behaviors. How we do this is the screen that the list of patients that a clinician would see when she logged in. You notice that some of the patients have a yellow or red flag next to their name. If somebody has a red flag, what that means is that in their most recent survey, that patient has reported a high level of suicidal thought with possible intention to act. And what we do immediately when we receive this is we email or text an alert to that patient's clinician with a link to this survey saying, the survey in the Insight software saying you've got a patient reporting very dangerous thoughts or behaviors. And then we also alert clinicians to more common, less critical surveys on whatever schedule they prefer. Typically, it's once a day, maybe at the end of their day or 9:30 in the morning. We'll send a email or text a list of all of their latest surveys that have come in. It's also useful to provide access to the detailed responses that patients have given. What we've done in Insight is we allow our users to click through and see exactly how patients answered every question. And we find this most useful in some areas like the eating disorder section, where what you really want to know is, what behaviors is this patient exhibiting? Are they making themselves vomit? Are they using laxatives or diuretics? Are they fasting? Are they engaging in intense exercise? Are they binge eating? And because we use a very responsive survey, the questions that the patient asks change based on how the patient answers previous questions. So if this patient had told us there were times that they ate what other people would regard as an unusually large amount of food, then they would have been asked, well, when that happened, did you lose control over your eating? And if so, how often has this been happening? And then finally, one thing that I strongly encourage everyone to do is to ask open-ended questions, because what we've heard from our clinical users is that they often feel they get a totally different type of information from their patients than they do in face-to-face interviews. Some people are just a lot more comfortable talking to the anonymous internet than they are face-to-face. So, let's move on to how you minimize staff effort. One way is by not requiring clinicians to choose which scales that each particular patient should be using. In the old style system, somebody would say, okay, well, I'm going to monitor that patient for anxiety and for depression, but I'm sure they don't have an eating disorder, so we don't need to go there. But by allowing the patients to tell us themselves what issues they're struggling with, then all the clinician needs to do is to pull up the results of the survey before they meet with the patient the first time. Obviously, allow patients to take the surveys on any of the different laptops, tablets, smartphones that they might have close at hand. All of our surveys are patient reported online. Everything in Insight is that way, and it works with, I think 80% of our patients probably take their follow-up surveys on a cell phone. Also, track the survey submissions so that your staff can easily see, for each patient, when did they last submit an update survey, and when is the next one due? And we allow, if let's say Jared is coming in to meet with his clinician tomorrow, and it's been a while since he's filled out a survey, all the program manager needs to do, or the clinician needs to do, is to click make a request, and Jared will be emailed or texted a link to his next survey and asked to fill it out for his counselor quickly. Now, we can also automate that and do for most of our IOP clients, where we will send out a request to all patients that are due for their next survey at one certain time each week. Typically it's Sunday afternoon, so that the clinicians have up-to-date information when they come in Monday morning. And obviously automate the survey requests as much as possible. Okay, so that's how we recommend you collect information. Now, how can you make sure you use those results to improve treatment effectiveness? First, obviously, you want to use the data to identify and help those individual patients that are not progressing well. It's very apparent if you're reporting the results in aggregate form. And you also need to aggregate and analyze your program-wide results. So in terms of helping individual clients, one of the things that we've done that's very useful for our clients is we provide group summary reports where we report the most recent data point for each patient being monitored for a condition as a function of how long they've been in treatment. And we label any patients in the yellow or red danger zone so that the clinical director can scroll down the group summary page and in a matter of moments be able to identify, which patients are really doing poorly. So she could go into her clinical staff meeting, for example, and say, hey, let's talk about Karen because she seems to be really struggling. Also suggest that you use the results to watch for signs of pending relapse. This is one of our very earliest adolescent clients. You can see that she came into treatment and seemed to be doing very well. And then all of a sudden, everything skyrocketed at once. And it's on the second page of the report, so you can't see it. But at the same time that her co-occurring disorder symptoms skyrocketed and her suicidal thoughts increased and her cravings increased, her relationships with her family declined, her satisfaction with treatment plummeted. It all happened at once. And unfortunately, this client was not yet set up in a way that they were able to take action on this survey immediately. And over the next couple of days after submitting this survey, this girl relapsed and had to go back into residential treatment. The other thing I would recommend is pay attention to those patients that just don't really seem engaged. What we've done is we have looked at match sets of patients with similar length of stay characteristics at the same treatment centers, some of whom left AMA and some of whom successfully completed treatment. And what we found was if we paid attention to just two different pieces, we paid attention to how frequently were they submitting surveys when we requested them, and what type of comments were we making, we could identify 79% of the patients at higher risk of leaving AMA. So what this would mean is, if your average patient is submitting a survey every 7 days and a particular patient is, submitting one every 2 weeks or 3 weeks, and they're never making any comments, or when they make comments, they're not hopeful, they're not talking about positive things, they're talking about, they're unhappy with something or other, those patients are a lot more likely to leave treatment. And obviously you want to act upon any unexpected findings. Okay, so that's how you use the individual data to improve treatment. Now, the other thing that we really recommend that you do is to aggregate the data and compare how you're doing to similar treatment programs. So use the data to analyze overall effectiveness. And what we report to our clients is information like, what percentage of patients were struggling with moderate to severe levels of depression at intake, and how had that reduced prior to discharge. We also recommend you compare these to norms, because oftentimes the raw aggregated data itself is not as useful as if you can compare that to data from other similar treatment programs. And then it becomes very apparent where you differ. So what we report for each of our clients is what percentage of their patients are successfully completing treatment. And this is one of the few areas in addiction treatment where there are national norms. There's a TEDS discharge database done each year that reports for different types of treatment, short-term residential, long-term, IOP, detox, etc. What percentage of patients are leaving treatment successfully, and what percentage are discharging under less successful methods. And so what you could see here is that for our Apollo Treatment Center, they have 69% of their patients successfully completing treatment, which is much better than the 56% national average. We also recommend that once you have your aggregate data and you've been able to identify potential areas for improvement, that you set performance targets and monitor your progress towards those goals. So this is showing a center that decided that they wanted to decrease the level of PTSD symptoms prior to discharge in their population. And you can see that, in fact, they were able to make a substantial improvement from one year to the next. All right, so that's talking about how do you monitor your patients during treatment and how do you use those results to improve treatment effectiveness. I want to stop at this point and talk a bit about following up with your patients post-treatment. So as we all know, commercial payers are under a great deal of pressure. The cost of healthcare has been rising, steadily each year for at least 20 years now, and they are looking for ways that they can reduce their costs, and they are paying particular attention to addiction treatment because it has been shown that that just the cost of treating physical conditions increases dramatically when a patient is also suffering from a mental disorder. So, if it costs $10,000 on average to treat, an episode of diabetes in a patient that does not have any kind of mental disorders or addiction, research has shown it will cost about twice that if they also have a mental disorder. And if they're struggling with addiction on top of all that, the cost goes up fourfold. So they know that helping patients deal with their addiction is really important to dropping the overall cost of healthcare. So one of the things that is becoming very apparent is in order to be able to survive long-term, addiction treatment programs need to be able to prove that their treatment is cost-effective. So how do we do effective outcomes research? The real challenge is it's very hard to reach this group of patients. It's notoriously difficult to follow up with addiction treatment patients post-treatment. And you really need to be able to reach about 60% of the patients in order to be able to report positive results. Because if you can't reach a patient, the assumption is that there's a reason you can't reach them. You can't count them in they're probably doing okay. You have to assume that they're really not. So we have been providing outcomes research to our clients for 3 years now. And here are some of the secrets of success we've learned. We've learned to take advantage of every possible way to contact them. We reach out by text, we reach out by email, we pick up the phone and call people. we make typically 10 to 15 attempts to contact a patient. We promise the patient's confidentiality so that they know that, you know, if they are aware that their clinician would be devastated to hear that, you know, they're back shooting heroin, they know they can tell us that, and the information will not go back to the treatment center except in aggregated form. Now, the only exception to that is if a patient admits that they're not doing well, if they're using drugs or alcohol, or they're feeling very poorly, we will ask at the end of the survey, would you like someone from your treatment center to contact you to possibly discuss going back into treatment? And if they answer that yes, then we immediately notify the treatment center. We also find that it's tremendously helpful to pay the patients a little bit. A little Target or Starbucks gift card goes an awfully long way. And the other thing we've learned is it's really important for us to get information from the patient about other people we can talk to if their cell phone number, for example, changes after treatment. And so we ask patients for the names of 1 or 2 family members or close friends that we have their permission to talk to and say, you know, Joe said he was going to be part of a research survey for us, and we haven't been able to reach him. Do you happen to know his new cell phone number? And they are comfortable giving it to us. So it's absolutely clear that you need to systematize your outreach program and have devoted outcomes callers if you're going to achieve a high response rate. So now let's assume you have outcomes results. How can you use your results to improve your bottom line? So there's 2 main ways that outcomes can make a tremendous difference for your treatment center. One, you can use your results to negotiate more effectively with your payers. And 2, you can advertise your results to attract more private pay clients. So let's talk about negotiating with payers. What you really need to be able to show the payers is that your treatment is going to save them money long term. So I'll show you some of the types of data that we report for our clients at 1 month, 6 months, and 12 months post-treatment. So what we report and what you'd be able to hopefully show your payers is that a high percentage of your patients are abstinent. What we consider the primary definition of success is what percentage of your patients are reachable and claim to have been abstinent for the last 30 days at 1 year post-treatment. This is what payers are extremely interested in. And then how does your abstinent rate compare to the national norms? Now, what I'm comparing to here is the last major federally funded addiction treatment outcomes research project. Believe it or not, that was done in the early 90s. This is the last federally funded addiction treatment research. And obviously a lot has changed since then. So as our base of clients that we're doing outcomes research with increases, we are developing our own set of norms, today's norms based on different types of treatment and so forth. Another thing you can show your payers is that the reduction in the number of emergency room visits during the post-treatment year as compared to the pre-treatment year more than covers the total cost of your treatment, and therefore you deserve a pay-for-performance bonus or a higher reimbursement rate. You can show your payers that not only did you help your patients with their addiction, but they were far more emotionally healthy when they left treatment, and they stayed emotionally healthy throughout the post-treatment year. And then you can also show the impact that treatment had on your patient's quality of life. Here you can see that 1/3 of the patients were not working or in school before treatment. And by 1 year post-treatment, only 10% were not gainfully employed or in school. So what you can do is use these results to negotiate with the payers for in-network coverage or pay for performance bonuses. And you've probably heard about, for years now, everyone's been talking about the movement to value-based reimbursements. It definitely is coming. It's happening. It's happening slower in the behavioral health care world than in the physical health world, which is already pretty far along the path. But I wanted to show you that there's a number of different steps in this process. If this is fee for service down here, and you think about, where you're promising you're going to treat, 100,000 patients over the course of a year for X dollars, that's what's, the end point, the full capitation model. But there's a lot of steps along the way. And the first steps are to maintain your payment with fee for service, but to negotiate a performance-based bonus at the end. There's no downside risk here. You could start using outcomes research, and you could go to your payer that you're in network for and say, we believe that if we're going to be able to reach X abstinence rate or this reduction in your emergency room visits, and if we meet this criteria, we want you to pay us a significant bonus at the end of next year on the result of, because we've saved you a lot of money. And payers are really very interested in moving in this direction. So I just wanted to point out that the starting down the path to value-based reimbursement isn't that risky. And then as you go, you will have more data as to exactly what your outcomes are, and you can, continue to take on whatever risk that you're comfortable taking on. So in addition to negotiating with your payers, you can also use your results to attract more clients. Publicize that you're doing progress monitoring and outcomes research. We have some of our clients that post their results on their website, or at least they, include information about why they're doing it and, why it's the best practices, and why that is a reason that prospective private pay clients or prospective any kind of clients might preferentially come to their treatment center. Post your results on your website and provide your results to sites like Shadowproof and Conquer Addiction, who are trying to use those kind of results to help families find effective treatment for their loved ones. So I've kind of come full circle here. As I mentioned at the beginning, I had created a website called Conquer Addiction that let you search for treatment centers by different criteria, location, what type of treatment, any special treatment services, that co-occurring disorders or adolescents or whatever, and potentially even buy health insurance. And if you search on this, you get a list of different treatment centers that could possibly meet your needs. And the ones that are tracking and will report their outcomes show up at the top of the search. And if you're interested in learning more about a treatment center, you just click through to the full page where you can see their website, you can see the phone number to call, and so forth. Unlike other sites out there, we don't collect information on people searching. That's not what this is all about. We're trying to help families find the best treatment. So being part of Conquer Addiction, there's no cost. As I said, we're relaunching it as a nonprofit. And I've had this on hold for the last 3.5 years because there just weren't enough treatment centers tracking their outcomes. But now that we do have a critical mass of treatment centers that are tracking their outcomes, we are getting ready to relaunch this. And we will be paying attention, giving higher ratings to treatment programs that can show that they are already tracking their outcomes, even if it's still too early for them to have results. So if you're interested, check out Conquer Addiction, conquer-addiction.org. As I said, there's no cost or anything, and we should be relaunching in the next month or so. So I promised a special bonus. These are some of the learnings we've had from Vista's outcome research to date. What we found in 3 years of monitoring patients, monitoring over 10,000 patients, is that treatment is effective very effective at reducing the levels of patients' co-occurring disorders. Also similarly very effective at reducing the level of suicidal thoughts and intentions. What we've shown, we've been able to follow up, this was a couple of months ago, with 1,400 patients who were discharged. We were able to follow up with them 1 month post-treatment, and we were able to show that 43% of the patients were reachable and claimed to have been abstinent since they left treatment. And for all 3 different time periods that we monitor patients for, follow up with patients for, 1 month, 6 months, and 12 months post-treatment, we found that among our clients, we had 40 to 44% of the patients were reachable and claimed to have been abstinent. We also found that one of the biggest things that made a difference was the percentage of people who completed treatment versus not completing treatment. And we also were able to look at the speed of relapse among patients who admitted relapsing sometime in the first year. 35% relapsed in the first week. Almost 60% in the first month. So, you could possibly share that information with patients about how important it is to get right into their aftercare programs. So I believe that in the next few years, outcomes research is going to show a couple of things that are very useful. It's going to show which treatment modalities are most effective for different types of patients. I believe that in a couple of years from now, we're going to be able to say, if you have a patient come in with this drug history and these demographics, she or he is more likely to be alive and doing well if you use this treatment methodology versus that treatment methodology. And I think that's going to be of incredible usefulness to the entire addiction treatment industry. And we're also obviously able to show which treatment programs provide the best treatment. Even among our early, small base of clients that have been doing outcomes research, while the average at 1 month was 43% reachable and claiming to be abstinent at 1 month post-treatment, our treatment centers ranged between 25% and 72%. So, clearly there is a difference in treatment effectiveness. And, following up with patients post-treatment and using the identical process for following up with them allows us to identify the treatment programs that are really providing the best results. So I'm hoping that you're interested in joining us in this exciting transformation of the addiction treatment world. If you are interested in learning more about our products, please go to start-outcomes.com and we will get in touch with you and figure out what would be best for you to help you get started. Or separately, if you're interested in our State of Addiction Treatment Report that was just released, please go to state-of-addiction.com and download the report. So I know I covered a tremendous amount of information. Let's go and see if there are any questions. And I will give you a moment if you have any questions to type them in. One of the questions we often get asked is if we integrate with different EHRs, and we do. We can typically bring data about your patients into Insight, and then we can export the up to the moment reports of how individual patients are feeling directly to their patient record in the EHR. And I don't see any questions coming in. My goodness. Hopefully that means I was providing so much information. I answered every question you have. So I will go back. I will, let me go back and show you. Again, if you're interested in talking to Vista about learning more about the Insight or Recovery 2020 products we offer, please go to start-outcomes.com. And if you're interested in downloading our State of Addiction Treatment Report, it's state-of-addiction.com. So since there are, let me just make sure again, no questions, what I'd like you to do, if you don't mind, is just take a minute and answer our quick poll. Okay, we do now have a question. Can you give a range for therapists in private practice in terms of what the cost is? Everyone that we've worked with has been a treatment center. We base our pricing for Insight on how many patients a treatment center monitors at a time. I would assume that a therapist in private practice would probably monitor, would probably be treating 10 to 20 patients at a time. If you wanted to use Insight on up to 20 patients, the cost per month is $299. And for that, you get access to the software, you get, the aggregated results, and we offer free email and phone client customer support 7 days a week. But the basic cost is for up to 20 patients at a time is $299 a month. And then you also get the aggregated results on an annual basis. And then the pricing goes up for, let's say, a treatment center treating between 20 and 100 patients at a time. Let's just pick arbitrarily 500 or 50 patients at a time. The cost for Insight would be $750 a month for that. And then the cost for Recovery 2020, it depends on how many patients we follow up with. So if we follow up with, let's say, 50 patients for a year post-treatment, the cost is $100 per patient spread over the course of the first year. So it's $33 at 1 month, $33 at 6 months, $33 at 1 year. So to monitor 50 patients, the cost would be $5,000. And there is an additional bonus if we're able to reach a high percentage of your patients, but that gives you kind of a good idea of the cost for the outcomes research. And we also, for larger treatment centers, we can randomly select, say, 250 patients, which limits the pricing to $25,000 per year for following up with 250 patients. So, all right, any other questions? Give you another moment for anything else to come in. Okay, I'm going to turn it back to Jessie for a poll. And I thank you very much for joining us today. And thank you also for C4 for hosting this webinar. C4 is an incredible organization that holds really useful, informative conferences and different educational events. So I'm really honored to be part of C4. Thank you very much and have a great rest of your day.